Good day. My name is Dr. Nikhil Oliveira, and alongside my colleagues Dr. Lorraine Joseph Kandato and Professor Dr. Georgi Chernev, I'm going to present to you a very unique and interesting case on nitrosamine and or Telmisartan hydrochlorothiazide induced nevus and epidermal scalp cyst. Before we start, I'd like to declare that all the authors declare no conflict of interest and there was no funding supported for this research. So I present to you a very unique case of a 57-year-old man. The patient, he reported with a presenting complaint of a solitary growing lesion on the scalp. His past history was diagnosed with a primary hypertension at the age of 13, and he is on oral treatment of Telmisartan hydrochlorothiazide 80 by 12.5 milligrams, half a tablet daily for roughly 10 years. The lesion was thought to appear in the last year of the drug intake, roughly 9 to 10 years after starting therapy with Telmisartan hydrochlorothiazide. The patient did not report any prior trauma or irritation on the scalp. There were no other lesions present on the scalp prior to taking his medication, as he has reported. He did not report any evidence of sunburn or any other medication, as his hypertension was well controlled with these drugs. He did not have any other concomitant conditions, and he did not report any family history regarding cutaneous cancers. On physical examination, there was a good general status. He corresponded to his passport age. He was of Fitzpatrick phototype 2. On dermatological examination, we identified a single ruptured cystic lesion, which was on the crown of the scalp, as you can see on the right image. It roughly measured 15 by 8 millimeters. It was irregularly shaped with uneven borders, and it had a crusted surface with marked areas of ulceration. Based on the clinical findings, we came up with differentials of squamous cell carcinoma or basal cell carcinoma. Paraclinical workup was done, including a complete blood analysis, which was within normal limits. There were no enlarged head and neck lymph nodes on palpation and ultrasound. Systemic physical examination was unremarkable, and imaging studies was performed, including CT, head, chest, and abdomen, which showed no signs of dissemination. A punch biopsy of the lesion was performed and sent for histological analysis, and to our surprise, as you can see here, histology identified unilocular cystic lesion, as you can see on the left image, with dense granular keratohyalin layers. And on the left here, you can see there is intradermal melanocytic naevi, as well as cystic dilations of the hair follicle. And so the histological analysis confirmed an epidermoid cyst. Once again, here on the images, you can see clear intradermal naevi with pseudohorn cysts forming, as well as cystic dilations of the hair follicles. So a planned surgical excision was done as per the gold standard treatment procedure, and this is done in order to prevent recurrence. The procedure was performed under local anesthesia, and the lesion was removed by elliptical excision with 2 millimeter surgical safety margins in all directions. As you can see on the image on your right, the preoperative markings of 2 millimeters as an elliptical drawing was performed with 2 millimeter surgical safety margins. The surgical excision of the entire lesion with 2 millimeters negative margins was performed. And here are the intraoperative images with the complete excision of the lesion on your left, with preparation and cleaning of the adjacent skin. And on your right, the image shows complete closure of the lesion with single interrupted sutures. Postoperative results, the patient came back 3 months later for a follow-up and showed positive signs of healing with minimal scarring of the lesion. However, ventral to the healed lesion, there was a development of a new lesion, which could be keratinocytic, spinocellular, or varicose-like. So, epidermal cysts are benign, slow-growing lesions derived from the epidermal layer of the skin. They develop as a result of proliferation of epidermal cells within the dermis. True epidermal cysts contain keratin and are lined by stratified squamous epithelium. However, you can also have pseudoepidermal cysts without this lining. These lesions may remain stable, progressively become larger, or in rare cases progress into squamous or basal cell carcinoma. Complete excision is gold standard for the treatment to prevent recurrence. Until now, epidermal cysts are considered to appear sporadically, either due to trauma or irritation, and can be seen in certain genetic conditions as well, such as Gardner syndrome, Gorlin syndrome, Favre-Ricochet syndrome, to name a few. Irritation, however, as a result of systemic drug use and the formation of epidermal cysts have been reported in the literature, especially with the use of BRAF inhibitors, imiquimod, and cyclosporin, to name a few. Epidermal naevi and epidermal cysts as adverse reactions are not limited to these classes of drugs alone, but are also being increasingly seen in patients using sartans. Sartan use and the development of epidermal cysts and dysplastic nevus has been reported in the literature in the past by Malev and colleagues. They have showed that the development and rapid progression of the pigmented de novo lesions into dysplastic melanocytic naevi, epidermal cyst, as well as BCC after the use of valsartan, hydrochlorothiazide, for over a period of 2.5 years. This development of the dysplastic nevus 2.5 years after onset of the combined antihypertensive therapy may have been triggered by carcinogenic adulterants or the active substance itself, according to the authors. Now, sartans have been in the spotlight since 2010, when a large meta-analysis of randomized controlled trials was published in The Lancet, which showed a modest but significantly increased risk of developing cancers. This was rapidly investigated by the FDA a year later, who published a meta-analysis finding no evidence of increased risk of incidence of cancer-related death in patients receiving ARBs. Since then, however, many studies from various research groups have detected an increasing trend in both melanocytic and non-melanocytic cancers, as well as rapid development of de novo naevi after administration of ARB, leading to rapid transition to melanomas. Some studies and clinical data that has shown the increase or the association of ARBs and melanoma. Here, a study done by Schmidt and colleagues in 2015 analyzed the population-based databases that assessed over 23,000 cases of the relationship between cutaneous cancers and antihypertensive medication between 1991 and 2010, just under 20 years. The findings were consistent with the association of long-term ARB use and malignant melanoma for both low intensity, i.e. low concentrations of the drug, with odds ratio of 1.53, and high concentration of the drug with odds ratio of 1.44. Now, another study which was done by as an international retrospective study formally presented by the American Academy of Dermatology as a poster in Washington in 2016 looked into the association between developing melanoma and basal cell carcinoma and the use of different antihypertensive drugs. The results were evident for the risk being more than double for melanoma after administration of ARBs, with a risk odds ratio of 2.21, that's over 221%, with a confidence interval, with a 95% confidence interval of 1.45 to 3.36. We suspect that dysplastic naevi could also have the same risk as this. And this was the poster that was presented, And here, that's highlighted in yellow, we can see, which clearly says a significant increased risk of melanoma was determined for ARBs with an odds ratio of 2.21, and for thiazides, which is odds ratio of 2.03 again, which an increased risk of basal cell carcinoma, which was also determined for ARBs. This same research group went on to involve a significantly increased number of patients with an even stronger association for non-melanocytic skin tumors after Sartan use or ARB use, which was found to be between 2 to 3 times increased risk for BCC with an unadjusted OR of 2.16 and an adjusted odds ratio of 2.86 based on the applied statistics. And this table was presented in the paper, and as we can see, for malignant melanoma with ARB use, it was over 2.25 unadjusted odds ratio with an adjusted odds ratio of 1.24, which suggests there's an 124% increased risk of getting this cancer. Same with basal cell carcinoma and ARB use with over 2.16 and 2.86 odds ratios for ARBs. As well as this, for thiazides, we can see for malignant melanoma, there was an odds ratio increase of 1.82 adjusted for thiazide drugs. Another paper published just 2 months ago in March 2022 by Sipahi and colleague, Sipahi in Turkey, presented ominous results with a highly significant correlation between the degree of cumulative exposure to ARBs and risk of all cancers combined, with a slope of 0.07. According in these trials, where the cumulative exposure was greater than 3 years of exposure to daily high dose, there was a statistically significant increase in risk of all cancers combined. So here we have cumulative amounts of data that suggest that there is an association of angiotensin receptor blockers and risk of developing cancers and cutaneous cancers. Now, up till now, it is unclear what was potentially causing the cancer in the patient, the drug itself or the contaminants within the drug. The clinical data was in favor of a possible association between using these drugs and developing cancers, but it was unaware of what is actually causing the cancer. Sartans and Telmisartan, or a combination of sartans with hydrochlorothiazide, have now been reported and described in the scientific literature as possible inducers of Nevus associated or occult melanomas, most likely due to possible contamination of the batches with nitrosamines. Now, nitrosamines are known to be strong carcinogens and are proven to cause cancer in various organs and tissues, including lung, brain, liver, kidney, bladder, stomach, esophagus, prostate, and skin. Due to the lack of inspection and/or formalization of the results by these big pharma companies and control bodies, the questions of nitrosamines as the main promoters of carcinogenesis has not been completely answered, especially as this data is difficult to establish, most often than not being institutionally or geographically determined. In June 2018, the FDA was informed of the production of sartans containing products that detected traces of N-nitrosodimethylamine, NDMA, in the active ingredient of a Chinese manufacturer. Subsequently, the European and American health services expanded the withdrawal of sartan after detection of NDMA in medicines manufactured by a second Chinese company and by an Indian manufacturer. There were several companies, including Major Pharmaceuticals, Solco Healthcare, and Teva Pharmaceuticals, who voluntarily withdrew their products from these sartans. And here there was withdrawal of many batches of these drugs. Now, do actions speak louder than words? The actions taken by the FDA and EMA refute the conflicting statements they publish regarding the safety of sartans and contaminations with nitrosamines. These actions, such as mass withdrawal of sartans starting with valsartan, the non-liability of any of the pharmaceutical companies with the actions of underreporting of the shared data and complete silence of the subject, the lack of formalization of this data regarding possible drug-induced forms of cancer, the lack of logical explanation as to whether the informal data on the registration of cancers are caused by drugs, as well as neglect in addressing the vast increase of clinical scientific publications. The FDA and EMA even refuted the initial Lancet paper, which was immediately blocked by these investigations, or so-called FDA investigations, which was limiting information to be spread to other scientific communities and the public. It took them 9 years, after which vast amounts of clinical data was published, that the FDA had to stop the production of these drugs and withdraw these batches. Interestingly, they also created a 6-month grace period in 2018, within which all companies in the market were able or were given an opportunity to purify and self-check production with respect to cancer-causing impurities. The story continues. In March 2021, the EMA officially imposed limits on the safe or permissible doses of nitrosamines in ARBs and Sartans. Is there a safe concentration that draws the line between the carcinogen versus a non-carcinogen? And if so, how do we determine this? The EMA imposes safe doses. However, they do not consider the possible contamination from other sources. And is there an accumulative effect? This is not considered. To what extent is the admission of minimum concentrations of 1 to 3 nitrosamines in one pill would be perceived as an adequate response by patients? Who is in the firing line here? It's the patients, which seem to be put last. What do we know so far? Well, the active ingredient of sartans in the form of ARBs in the skin may potentiate melanogenesis, leading to the formation of Nevus-associated melanomas, as well as other adverse reactions. However, contamination in the form of nitrosamines could also be contributing to the formation of precancerous lesions. Is there multifactorial etiogenesis? We do not know. We have been blocked from studying this. The increased incidence of official patients in Europe and in America in the scientific literature who have taken sartans and have developed rapid development in parallel with known side effects of nitrosamines of colon cancer, prostate, bladder cancer, and melanocytic and non-melanocytic skin tumors. The subsequent actions taken to withdraw potentially contaminated drug batches, while ignoring calls to take action to penalize these drug companies against poor manufacturing standards, all at the cost of the patient's health. The blocking and dissemination of the data at regional and international level, leading to reduced awareness of patients themselves and subsequent manifestations of multiple and heterogeneous tumors. The implementation of permissible levels of a known carcinogen without addressing other potential sources of contamination that could add to the concentration of overall nitrosamines in the body. What about hydrochlorothiazide and melanoma? Studies have looked at 22,000 cases of melanoma, and overall 413 cases were classified as high users of hydrochlorothiazide, yielding an adjusted OR of 1.22 for melanoma. However, no clear dose-dependent pattern emerged between hydrochlorothiazide and use and the melanoma risk. When stratifying the histological subtype, there was a higher OR or odds ratio occurred for nodular melanoma with 2.05 and lentigo melanoma with 1.61. Another paper published by Habel and colleagues in 2021 analyzed the data of over 9,000 cases of melanoma against over 250,000 cases of controls, and showed an increased risk of melanoma with odds ratio of 1.11, with an even more elevated risk of lentigo maligna subtype with 1.57 odds ratio. So hydrochlorothiazide and melanoma. Hydrochlorothiazide use as monotherapy has been linked to skin cancer and has led to several countries, including Denmark, to downgrade its usage in the general population. It has even been published in the adverse drug effects label. It is unclear as to the role of these ingredients in the form of nitrosamines, HCT, Sartans, could potentially have a synergistic effect on the development of melanomas. The lack of possibility or deliberate non-implementation of subsequent formal disclosure of checks for the presence-absence of nitrosamines in certain geographical areas, even in Europe, certainly makes it difficult to clarify a number of dilemmas, such as nitrosamines in sartans and thiazides and their leading cause in triggering carcinogenesis. The fact that the number of clinical observations confirm the simultaneous manifestation of skin as well as non-cutaneous cancers, as well as Nevus-associated melanomas seen by rapid development after the use of sartans, definitely suggest a synergistic but at the same time different action of these substances within the carcinogenesis. So in conclusion, in our case, the patient developed an intradermal melanocytic naevi alongside an epidermal scalp cyst after the use of Telmisartan hydrochlorothiazide. There's copious amount of scientific data in the form of retrospective, multi-centered studies as well as clinical data suggest the potential role of Telmisartan hydrochlorothiazide with the possible contamination of nitrosamines in Nevus-associated melanomas as well as other precancerous cancerous lesions. The possibility of these lesions occurring as a result of the intake of Telmisartan hydrochlorothiazide is worrying and cannot be ignored, as much of the scientific literature points to this direction. The introduction, monitoring, and recording of dose-dependent time intervals for the transformation of normal cells into precursors of neoplastic cells, I think, are the next steps in the right direction. With this, I'd like to thank you for your attention, and please check out bulsds.com, which is the Bulgarian Society for Dermatologic Surgery, to look at the work we are doing here. Thank you.